Today's going to be the first of a regular series of webinars exploring homelessness policy and practice. And I think it's a really important activity for us all to be engaged in. If we're going to end homelessness, we need to be constantly thinking and examining what we do and interrogating new ideas and sharing also with each other. Today's particular conversation arose out of discussions about the need for supported housing options for people without homes who have complex support needs. And this issue around supported housing is something Homelessness Australia is doing some deeper work on to identify how we can get more supported housing options out of the processes that are happening around mental health, the NDIS, and homelessness reforms, and ideally ending up with a situation where we have more supported housing. And of course, supported housing options for young people is a really important part of that overall project. If you're interested in supported housing for young people, which I assume you are because you're here talking about integrated support for young people who are homeless, I do encourage you to join the Home Time campaign. Shauna will put a link to joining that in the chat, so you can explore that a little bit more if you're not familiar with it. So discussions about today's session arose in conversations I was having with the fabulous Shauna Moore, who's with us on the session, who I'm working with on the Home Time campaign. And through those discussions, learnt that Dr. Jo Henderson was coming to Australia to inform the Home in Mind project. So Home in Mind is a partnership between Melbourne City Mission and Origin that's trying to nut out how to address the really significant gaps in our responses to homeless young people who have mental ill health. And of course, the work that Jo's involved with in Canada sits across both of those areas and fills those gaps. So it's a really exciting to have that knowledge to share with all of us today. So how this session's going to work is that we're going to hear first from Professor Owen Kalaki from Origin, and then we'll hear from Dr. Jo Henderson about what a holistic system for homeless young people experiencing mental ill health looks like in Canada. And then to anchor that in our Australian context, we've got a fabulous panel discussion. I'll just let you know that unfortunately Dushka Dobson's unwell today, and so Shauna's filling in their place. And then at the end, we'll have time for your questions and contributions. So now I'll hand over to Professor Owen Kalaki, who's Chief of Research and Head of Functional Recovery at Origin, who's going to share a perspective on the challenges of meeting the needs of homeless young people from a mental health perspective.
Owen has some terrific things to say, so I'm not going to try and step in and fill those shoes just at the very beginning, but I will step in just to say that obviously from Origin's perspective and our rationale for wanting to partner with Melbourne City Mission on this Home in Mind project is a recognition that we need a much greater focus on approaches which improve service engagement, such as care coordination, outreach programs, and involving young people in the delivery and design of mental health and homelessness services. And there's a real need for mental health services to explore what new and different approaches might look like to make sure that these young people are actually getting access through the front door, if it is a front door, or through seeing people that can help them with the mental health issues while they're also experiencing homelessness. We thought one of the things that we really like to do at Origin is learn from approaches overseas, particularly those that have got a focus on early intervention for housing needs at the same time as intervening early for mental ill health. So we're really thrilled to introduce you all to Dr. Jo Henderson from the Centre for Addiction and Mental Health in Canada. They've been leading work over there across that country to develop integrated youth mental health services. And most importantly, these integrated youth mental health services include housing and homelessness supports in them at the moment. So happy to hand over to Jo to take it away for a presentation.
Excellent. Thank you very much for that introduction. And I'm just sharing my screen and we will get started. So I'm really excited to be here as a guest on these lands and to have the opportunity to both learn from all of you through the discussion that will follow and to share with you the work that we've been doing. As we go through, I just want to start off by saying the information I'm sharing with you today is a reflection of many people's expertise. I just have the privilege of sharing it. Most importantly, we work in partnership with youth with lived and living experience and expertise of mental ill health, substance use related concerns, housing related concerns, and other concerns as well. And so I just want to acknowledge that the ideas that I'm putting forth are shared by all of us, they're not my ideas. I won't bore you with homelessness in Canada. I've had the pleasure of speaking with other colleagues who are here today and understand that these numbers are pretty similar to Australia's context. And so what I think the takeaway is when we think about how to plan integrated service delivery is to really think about who is being most poorly served by our current systems. We need more in Canada, we need more investment across the board. That's probably true here in Australia as well. And we need to think about where are those particularly grievous inequities so that we can ensure that those are prioritized. In our partnership with young people that has extended over quite a long period of time, we've had the opportunity to really understand what would need to be part of service delivery. Kate, I think I'm getting some background. Maybe someone needs to mute themselves. So what needs to be part of a service delivery model that can better meet the need of young people who are experiencing both housing challenges and mental ill health? In Canada, we use the language of precarious housing. We can talk about that after, but really what we mean, these are young people who are experiencing homelessness or at very high risk of experiencing homelessness. And obviously, people move in and out of this experience, and so it in part captures that. What we heard that from youth was in order to address their mental health related concerns, it was really important for us to attend to basic needs, housing being one, but also many other basic needs as well. Attention to building life skills and providing developmentally appropriate supports for the transition to adulthood, autonomous decision-making in ways that support young people in managing and achieving their optimal health outcomes was also identified as really important. Safe spaces and non-stigmatizing, non-oppressive practices have been identified by young people as being critical to integrate into service models to meet their needs, and to ensure that youth services come together under one roof so they're easily accessible across multiple different domains, with system navigation supports when transitions to other services are necessary, but ideally that most needs most of the time can be met in one location and experienced as seamless. Even though multiple different organizations may be providing those services, youth had really identified a hope that those services could be delivered seamlessly. Really importantly, young people wanted to see people like themselves, people with lived experience, peer support workers, outreach workers embedded as critical and equal members of the teams who work with them. And so in Canada and in Ontario in particular, we had many different organizations, many services, each operating independently with their own boards and their own visions and their own staffing. And really, there wasn't a system, it was a collection of services. And our goal with integrated youth services has been to build a cohesive and coherent system of services that surround young people, keeping them at the center of decision-making about the services that impact them. And the services we bring together cut across services for youth experiencing mental ill health, as well as substance use, health-related services, of course, housing and shelter services, supports for young people who are connected to the child welfare, child protection system. I forget what you call it, refer to it here. Youth who are experiencing contact with the youth justice system, employment and education supports, and we've been very fortunate. I also want to say we've been very fortunate to learn from many innovations that have happened in Australia, and really this kind of reciprocity across the two, thinking in particular about the IPS model that you've done so much work here in Ontario. Public health, we cross hospital and community-based services. And in Canada, we have a history of colonization and tremendous harms caused to Indigenous, First Nations, and Métis peoples, and thinking as part of Truth and Reconciliation, thinking about how we partner with those communities to ensure that the needs of the many nations in Canada are being met. And so within the Youth Wellness Hubs Ontario model, we take an all-of-community approach. We work with communities to bring together all different resources and put their resources on the table and to build something new with those resources. We're strongly guided by values. We focus on creating central locations, convenient hours, safe spaces, and youth-friendly staff. Within our hubs, so in Ontario, we have, because we operate as a network model, we have 22 networks, but those 22 networks run more than 22 different locations. All of our networks are expected to provide support for youth experiencing homelessness or precarious housing. And in addition, 12 out of the 22 networks provide very specific housing supports. In terms of the kinds of supports that we're offering in these integrated youth services models that are unfolding in Canada, and I'm talking in particular about Ontario today, we have them sort of divided into low intensity, moderate intensity, and high intensity services. Our low intensity services are also low or no barrier. They're often anonymously provided, and they give young people access to basic supports. Our centers, unlike conventional mental health services, we are a mental health service, but unlike those typical clinical environments, we create spaces where young people can walk in. They'll be greeted by a living room-like feel with sofas, free access to food, to hygiene products. They can access Wi-Fi, charge their phones, hang out, and do that without needing to tell anyone who they are or why they're there. And so really creating that place that is the young person's place, as opposed to an organizational space. Access to harm reduction supplies are common across all of our hubs. And we have a kind of low intensity supports around prevention as well. Our basic supports include the usual kinds of things that you would probably think about given the kinds of work you do. So transportation support, so that can be direct funding, bus tokens, but we also bring services to young people, as I'm sure many of you do. We provide, so we're a mental health service. So this is unusual in the context of mental health service. We provide access to food, food pantries, food hampers. We have cooking programs. We engage young people in having community meals, cooking for each other, cooking for others in their community, and eating together, providing access to hygiene kits across Ontario. The services have sort of these core values and core components, but they respond and reflect the local context. So in some communities where there are robust youth homelessness services, then we may have fewer of these kinds of services. But in other communities where there are, like in a community called Kenora, for example, there are no youth homelessness services, then that hub has many more services. So they, for example, have shower facilities, laundry facilities, a much more well-established range of services that to meet the needs of those youth. We give access to Wi-Fi, of course, but we also provide phones and phone plans, access to clothing, and other things. In terms of services where people have to identify other services where they need to connect with others to access the services, those would be things like your regular access to housing workers, peer support workers, income support workers, education, employment supports, access to legal services, and of course, access to mental health, substance use, and primary physical health care, sexual health care services. The ones I think that are most interesting are really our high intensity services. And these are where we really have brought together services that are typically found in the housing, homelessness sector, and services that are found, of course, in mental health. So one of our hubs, for example, has emergency beds right in the mental health hub. Those are not mental health emergency beds, they're actually housing related beds. We also work in close partnership with many other communities where we have warm handover plans. So if young people come in, though we may not have beds on site, we actually do supported transitions, walking with young people down to access shelters. We have fully integrated mental health, substance use, and physical health supports. We have really interesting crisis supports. One of our hubs, for example, in Toronto, where we don't have sort of homelessness services on site, have established protocols in collaboration with emergency services and local hospitals, where young people who are interested in having that level of support can sign up to receive that level of support. If they are picked up by ambulance, maybe related to exposure to weather, hypothermia, or overdose, toxic drug supply, drug poisoning, or they present in a mental health crisis, picked up in an ambulance or present to hospital, they will our service providers will be notified, and we will send staff to the hospital to meet that person and to ensure that they're not discharged without support. We advocate at the hospital setting, but also ensure that there's that warm handoff into service at the end of that hospital visit. So we also have interesting models where we position some of our Youth Wellness Hubs Ontario workers in hospital, similarly, so that youth who are presenting, who may not have signed up for any kind of service yet, but who are presenting with overdose, for example, are just many youth in Ontario discharged without plans. This allows us to ensure that if they are interested, they can have connection with a worker immediately. We have robust, so the intersection between mental ill health, substance use, and housing precarity is significant in Ontario. And so making sure that within our mental health services, we have really strong substance use related services has been very important. And so we do withdrawal management, outpatient withdrawal management, harm reduction related services, and treatment for substance use related concerns. But we also have robust partnerships with our rapid access addiction medicine clinics to support even more robust withdrawal management for youth and long-term treatment. And we have more recently become much more involved in anti-trafficking programming and supporting sexually exploited youth over time and to exit those environments. I think one of the important things are really, or some of the important things are cross-cutting themes that cut across all of the kinds of services we deliver. We focus on providing really inclusive atmospheres, which means including young people who might be actively intoxicated. This is often an exclusion in mental health services. And often that results in our most vulnerable young people being excluded from services, including youth who are experiencing homelessness. And so we really focus on that. Other ones that I think are really important are measurements. We can't know if we're building a more effective system unless we measure robustly over time. And so common measures and data and a common data platform across all of our hubs has been really important. And then the importance of staff training and staff support and building communities of practice to support one another. I just say draw your attention to a couple of examples to give you a little bit more, and then I'll be wrapping up. I have about 4 minutes according to my timer. So excellent. So one of an example of a hub in Ontario is located in a region. It's actually a collection of 4 regions: Kingston, Frontenac, Lennox, Addington. We call this KFLA. Kingston is a university town, but the area in general is a rural area in this context. So this is kind of, I think, like what's really interesting about the integrated youth services model. So I'm going to say it again. We are a mental health service. We're a youth mental health service. But in KFLA, the lead organization of that integrated table of organizations is a housing service organization. So they're eligible to receive funding from government. They, by their community, all of the organizations in the community came together to, through a consensus process, determine who should be the lead organization, and they were identified as the important lead organization in the community. So they provide an administrative host function. They help keep the work happening and the integrated governance happening. But what it also does is it embeds the attention to housing related issues throughout our mental health services. And then because we operate as a network of networks across the province, that then influences all of the other youth mental health integrated youth service networks to pay greater attention and to see the innovation that's happening and then to replicate those things. They are using Housing First for Youth in their context. Kenora, oh, and I'll just say, you can see both in the previous slide and in this slide, the kind of environments that are, this does not look like your clinical mental health service. These are very different. They're youth co-designed environments to create that sense of safety and more of a home or a living space. And so our Kenora hub is in northern Ontario. It is one of these communities where young people move from their remote communities, sometimes flying communities. They come into town. They come into town to access high school, secondary school, and they come into town to access economic opportunities, and for various reasons, they sometimes get trafficked into this main town. And the hub there is led by the Kenora Chiefs Advisory, which is a coalition of 9 First Nations in Ontario. They don't have a youth shelter system in the region, and so the hub provides many of those needs. There we're focused on trying to build a new subsidized housing unit. They do a lot of land-based healing, and so creating opportunities for youth who are experiencing homelessness or precarious housing to have those kinds of opportunities as well has been really important. In London, Middlesex, this is another Youth Wellness Hubs Ontario integrated youth service hub, where a housing service provider is the lead organization and provides the leadership for the whole community around the delivery of mental health services. And again, they have really done a lot of really innovative work. They're using Housing First for Youth. They have mobile teams and rapid rehousing. One of the things they've done particularly well are their social enterprises. So again, this gives us an opportunity across all of our networks to build capacity around these kinds of approaches. And then lastly, Renfrew County is one of our hubs, again in a rural area. There's kind of like a larger town and then a vast rural area. This is, and you can see it's located in a house. This is where we are, not experimenting with, that sounds a little, I don't know, a little bad, but where we have 2 short-term crisis beds for youth who, and they can access them through the hub. The goal is really to just have them for 72 hours and to be able to, with support, transition them to other shelter opportunities. But again, this is an innovation we're working with to see how it can work. There we go. You see, I actually did have my timer going this time. And there we go. I am at my last slide. Thank you very much. I look forward to the discussion. I'll turn it back over to you.
Thanks so much, Jo. So I'm going to introduce the panel now. I'll just take you off spotlight. So I'm going to introduce the panel now. We're going to try and sort of bring that model into an Australian context and think about what could change in Australia to try and achieve that level of integration. So I'll first introduce Kristen Simonson. As an experienced peer worker in Melbourne City Mission's mental health service at Front Yard. Kristen has a wealth of lived experience across mental health and homelessness services and is one of the founding partners driving the Home in Mind project. So welcome to Kristen. I'll probably can't keep talking and spotlight you at the same time, so I'll do that in a sec. And Shauna Moore is a social justice lawyer and the head of policy and advocacy at Melbourne City Mission. Shauna's most well known for decades of experience driving systems change to improve the lives of children and young people experiencing homelessness. So welcome to Shauna. And Vivian Brown, who you met before, is the Director of Policy and Engagement at Origin, the National Centre of Excellence in Youth Mental Health. And Vivian lives and works on Wurundjeri land. At Origin, Vivian's responsible for the strategic leadership and coordination of Origin's policy and governance activities. So just bear with me while I take myself off spotlight and bring so that everyone can see Vivian and Shauna and Kristen.
Ooh.
Just have to find you. There you are. Kristen, there you go. So can I start with you, Shauna? Can you tell us about what you observe working in homelessness that's similar to the system design that Joe's outlined, and what do you think would need to change to get to that level of integration?
Okay, thanks, Kate, and thanks for having me. And yeah, apologies, Dushka was supposed to be the wonderful person on the panel, but it's unwell, so I'll do my best. I just wanted to also acknowledge in the Home in Mind project that we really are being shaped and led by the living experiences and insights of our wonderful lived experience advisory group, of which Kristen is one of the members. So a lot of the work is really being driven by them, and I'm just a mouthpiece today. But in terms of your question, Kate, I wanted to just define, when we think about young people experiencing homelessness from the context that I'll respond, we're talking about unaccompanied young people who are experiencing homelessness and have mental health support needs. So these are young people that not only don't have a fixed address, but don't have that parent or primary carer in their lives. They're in youth homelessness, generally in the crisis sector. And our system is currently built in Victoria and Australia that really relies on that fixed address. When we go to hospital, we get asked who's taking us home, and the fact that we would, expectation that we would have a home. So, these young people have got these significant barriers in terms of accessing the mental health system because they don't have that support and don't have a fixed address, and are generally escaping really quite violent or neglectful homes. In terms of Joe, what we've seen in Canada, thanks Joe for your wonderful presentation again, we do have some, and I'm speaking on behalf from Victoria's context, we have some great integration between housing and mental health support, similar to what we've heard. They do exist localised, but they're really progressive pilots or flagships, and they're not, I guess, built into the system as a whole. To name some, we've got the Housing First models that we've seen pop up, or the Housing First for Youth, based on the Housing First for Youth principles that have that bi-directional support. At MCM, we've got Front Yard that we mentioned, where Kristen works inside Front Yard, which is a big kind of crisis response with that high intensity that Joe mentioned. We've got the mental health service check-in funded by the health partnerships. We've got the Children's Hospital in there, AOD, Legal, Centrelink, family violence workers now, and then we've got 2 levels of integrated accommodation, both short and long term. So that's kind of one example that comes to mind when I see the work that's been done in Canada. And I think there was quite a lot of work between the 2 countries when we were designing and setting up front yard. We've got some great outreach programs within Victoria. The Youth Outreach Recovery Services by, I'm not sure if anyone's on the call here, but by NEMI and CoHealth and each. They're really flexible short-term to medium-term outreach across Victoria. And then we also have Wellways Homelessness Outreach Mental Health Service that is also a flexible sort of outreach program. All of these programs have their limitations, and of course, as I mentioned, are really only pilots, or not pilots, but they haven't been expanded, so they're only in certain areas, and they've got this postcode justice issue that occurs for young people depending on where you live. We are looking forward to the 500 supported housing places that's been promised in the Victorian Royal Commission to Mental Health. That hasn't been funded yet, but that's something that we're really looking forward to, that aligns with what we're seeing in Canada. However, you know, we're still very much in a position where we've got the fragmented systems, and that's not only between mental health and homelessness or housing, but also federal and state policies. We have a lot of, you know, as a result, we've got a lot of young people. 30% of our young people in homelessness have, you know, been discharged into a homelessness service from a hospital or from an emergency service. We have this ongoing cycling between, you know, the emergency departments and the streets or refuges, and that is really as a result of the two systems not working well together, and the complete lack of policy that is integrating housing and mental health support. In terms of what can change, just at a very high level, we need to see structural policy and investment reform at that federal and state and territory level. And we've got some really great opportunities with the National Plan, National Housing and Homelessness Plan, and also the agreement that's currently being negotiated by all levels of government. So we really want to see, you know, if we're going to kind of try to get to where Canada is, and it makes me wonder why, you know, we've got all the research and evidence base here that Jo's mentioned that's helped kind of lay the land for Canada. How come we haven't done it here? It's a question. But what we really want to see right now is that longer term support for young people embedded in the agreement, in the National Housing and Homelessness Agreement, with those outcomes that are relating to mental health and wellbeing, and that also partnered with the dedicated housing that we need for young people, because we know that they can't access the housing because of their lower rental income, and because of their lower, experience in the rental market. So we need to see these reforms at a really high level in order to be able to provide an integrated response across the two systems across the country, and not just some really wonderful housing first or other pilots occurring because we've got these health partnerships funding, you know, 18-month things here and there. So that's probably where I'd want to see the change and where I think the opportunities are, Kate.
So sorry, I was saying, Kristen, you've accessed services as a young person, and then now you work in service delivery. So I'm just wondering if you can share what are the gaps that you've observed in the current responses, and what would be your priorities for change?
Sure. So I first accessed supports as a minor. So it's sort of almost 25 years ago now, which is scary. But the scarier part is that in terms of mental health supports for unaccompanied young people, nothing much has changed in 25 years. One of the aspects for me was having to relocate from a regional area in order to obtain support. That's still happening. We've also got a lot of gaps. The gaps essentially sit between the systems. So we've got, you know, AOD sitting in one end, mental health sitting in another, and housing sitting somewhere in between. And because they're so siloed from each other in terms of funding, policy, everything, we see young people just cycling through each one, unable to get supports from one particular service, like mental health, if there's any substance abuse or if there's any homelessness, because mental health will say, oh, well, that's too complex, or it's situational, or they're wanting to go into hospital for secondary gain, which is a clinical term for they just want a bed. So yeah, for me, I think the priorities are the 500 supported beds that we were promised, that the government made a commitment to following the Royal Commission into Mental Health. The way our policies are set up, the way the health system is set up and the culture within it, there needs to be a lot of overhaul before we can see some real change. But at a very, very base level, those 500 supported beds, and we just need a lot more programs that work outreach, and removing the requirements for a fixed address and requirements to be within sort of a certain area.
Fantastic. Thanks for that. Vivian, can I pass over to you and to share a perspective from mental health services and what change you think need to be made to youth mental health systems and services to improve the care to young people, to homeless young people?
Thanks, Kate. And I think Kristen and Shauna have both touched on quite a lot of improvements that could be made, that we're aware of. We certainly know that, the gap in mental health support for unaccompanied young people is, widely driven by a number of factors, including workforce and funding constraints, which we have in both sectors. But there's a lack of kind of outreach services within mental health care, I think, at the moment that really meets the demand, particularly where young people and homeless young people have been saying that they want the services to come to them. The intake and discharge processes at the moment, and some of the requirements around identification and fixed address are obviously clearly problematic at the moment, very much embedded in our system, and we need to be looking at how we can change those to make the services more accessible. And then I guess, as Shauna was saying, it's just around the lack of integration at the moment between the mental health and homelessness. And it's more about policies and systems rather than services. There's plenty of great work happening where services are trying to integrate with each other. But I've been in a number of presentations with Joe today, who's also made the really great point that, from a government, we hear integration sort of spelled out by governments in all sorts of policy documents, but integration doesn't happen when you're just being told to integrate in words in a policy. Like, there has to be actual commitments from government to work through what the enabling structures are and functions that would support services to integrate with each other, bring everything that they've got to the table, and what other supports then, once you bring all of the services to the table and work out who can provide what in a service designed to meet the needs of young people, and then work out what the gaps are. And that's where government can then also come in and help fill those gaps, whether it's data sharing platforms, coordinating structures, roles that actually focus on care coordinator, service coordination as well. So I think that's sort of one of the things that I just really have found probably is a real opportunity still within looking at reforming and restructuring mental health services. And I think for us as well, we've talked a lot about, in mental health anyway, the sort of the words, but the missing middle being rolled out quite a lot over the last few years. Really, we want to identify that that's the missing middle for us, as a missing middle in a system, not a population group, but for the young people experiencing homelessness who are unaccompanied, that is that group that, the system is missing in that spot for them. So, and we've got this really perennial kind of issue where we've got services that are there to support people presenting with milder mental health issues, a system that responds to young people when things get to a serious or even a life-threatening point of crisis, like emergency departments. But what's sitting in the middle of that, particularly for young people with mental health issues and that are also presenting with other complexity, including homelessness and housing precarity, is missing at the moment. And so I think what's been really interesting about listening to the approaches in Canada that Joe has been talking about today, and sort of more broadly to some other government stakeholders, is that we need to understand now in the Australian system what integration looks like. Is it possible to sort of get people around a table to sort of look at what everyone can contribute in terms of the various service offerings they have, take their organisations sort of Joe said, logos and egos kind of out of it and go, if we put all of this together, we're actually going to deliver together a service that young people need and want. And so for us, we kind of, it might not be about building a whole new platform in the system. It's about looking at what we've got, bringing it together and then working out where the gaps still are, and then asking government to come in and start funding those gaps. And then I think, I mean, I touched on outreach before. It did sound like from the interviews that we've conducted already through the Home in Mind project with young people, the lived experience have been so generous in giving us their time and their experiences, but they're really calling out for outreach, and there is too much of a reliance still, I think, in mental health services for young people to come to the service, come through a front door, and for many young people in this situation, that's just not feasible. And then if they do come to the service in the front door and can't be offered care, then it's only going to continue to re-emphasise to them that this service system is not for them. And then it just sort of cycles into a point of crisis where the first place that they do access services is an emergency department. So I think, again, looking to other models, we've been able to build in, like in the Canadian experience, sort of more 24/7 contact, having young people being able to identify that they're happy to be sort of put on to a, for want of a better word, register, whereby if they do come in contact with some of these points of first response, whether it's police or emergency departments, that we are proactively able to then reach into those settings, connect with those young people, and then work with them to make sure that they've got support on exit and not being discharged or sent away from the emergency department. I suppose we've talked quite a lot too about the difficulties and even getting admitted into inpatient care, where hospitals and other services have a concern that they won't be able to be in a position to discharge them into secure accommodation, and are not able by law to discharge them into homelessness. So while it's a very well-intended piece of legislation where you don't want people being discharged into homelessness, unfortunately it's had some I guess adverse and perverse consequences where it's making it more difficult for young people to actually get admitted into care that they need. And so I think there's also an opportunity for mental health services and the system to be looking at how we can address some of those barriers without, you know, again, stepping away from obviously a clear, you know, and important commitment to make sure that young people are supported into accommodation and mental health care at the same time.
Kate, can I also just quickly add, forgot to mention, you know, one of the big kind of structural issues that we've got is that a lot of the mental health support that's being provided is federally funded through the Medicare rebates. And so, you know, Headspaces and a lot of other, you know, doctors and GP, like when a young person hasn't got a fixed address, they don't know where they're going to sleep, they're in crisis, being able to meet an appointment and not kind of have chaotic attendance means that they're getting excluded, and, you know, 2 strikes you're out kind of rule. So that's how our whole system's being funded. That is completely, you know, that's excluding this cohort who are unable to always meet an appointment time. So I think there's some real structural issues that we need to look at in order to be able to provide care to this group.
Yeah, I think one of the things that's really exciting about it is the integration across the health system, which, I mean, we've got lots of models of integration across community services, but bringing actual formal hospitals into the network is really powerful, but incredibly different cultures. And I imagine that there's been some real challenges in that integration. But so now we're at the point where there's opportunity for to hear from the audience, both questions or reflect. Start with you, Heather. If you just come off mute. And
Hi.
then...
Thanks, Kate. Thank you for that presentation. That was great. I just wanted to ask whether, because I'm a Heidi worker, so for GB Health, whether it's considered, because what you're describing is basically what our guidelines are saying. We go do outreach, we go into homelessness youth services, we do education, capacity building, building bridges between area mental health and these homelessness services, plus going to wherever the young people want us to go, we'll go and see them. I'm just wondering whether there's an opportunity to increase the funding for Heidi workers. And because I know that there's only about 8 of us in the state. So that would probably be a good start, I would think. Is that something that's been looked at all, or?
We
that.
would second that 100%. So at Front Yard, we have had to partner with another organization in order to get dual diagnosis clinicians in my team, because it's something we've identified as being really, really needed. We did approach for a Heidi worker, but obviously, there's not many of you guys.
No, there's only about 8, and a few of us are regional. But ultimately, the work that we're doing is what you're saying today is what we're sort of doing. And I know that a lot of services around the state aren't aware that we even exist, which they could probably access us. So, might need to look at that as well.
Yeah, I think what we've found is a lot of what we do at Front Yard is a lot of what Heidi does as well. And there's these pockets. There are pockets of organizations that have really good programs. Heidi's an amazing program. But the level of there isn't the integration. And so we're missing so many young people who are ending up, just representing at EDs all the time, or, getting into the correction system, particularly with a lot of our young men who need that dual diagnosis support.
Okay, thanks.
Thanks, Heather. I can't see another question at the moment, so I'll ask one. I'm just wondering, Jo, if you can reflect on that journey of integrating across the formal hospital system and community services, like what that journey looked like, because it seems like a big stretch to me to get that integration happening.
Yeah, I agree completely. The culture difference, you have kind of a biomedical versus community-based approaches that tend to be more social determinants of health. You have kind of big institutional structures with experts, lots of education and lots of resources. And then you have community-based organizations. I think I think part of what I've tried to do in my own personal career is to have a lot of empathy, to really try to understand the groups we're working with. And so really trying to sort of stand in the hospital context, understand what their experience is, what would they need out of a new initiative to integrate, what would make it worth their while, what do they need to hear. Often, evidence is highly like the sort of conventional form of research evidence is highly valued. So, I've been involved in big studies demonstrating that the needs of young people presenting to community-based organizations are equivalent or exceed the complexity of youth presenting to hospital-based contexts. So, being able to demonstrate that there's a fallacy of the hospitals deal with kind of young people who have the greatest level of need, and being able to show the inequity in the kind of language that resonates for them in the mismatch between the resourcing and the needs in the community. I think standing with community, standing with young people to understand what do they need from the hospital system, how do they need it to be different, how do they want those institutions to show up? Because part of it's a bit challenging. You bring institutions who are used to being in charge, whether they're hospitals or they're big, large community-based organizations, they come into those spaces and they expect to be the people talking, and they expect to sort of lead the decisions and lead the conversation. And so being intentional about dismantling that into a different way of relating to one another, I think is really important. And so kind of really, thinking about how to have separate conversations and then joint conversations, but really thinking about how you're bringing you're learning before you bring people together so that you can facilitate in ways that are more helpful or more meaningful and don't replicate the inequities that already exist in the system, especially around power and resourcing. And then modeling, like for me, it's really been in my own career. I was telling a different group, but similar conversation, like the very first time we started this integrated model of service delivery, the very first kind of iterations in 2005, we had $3,500 to support the project, like virtually no money. And even with that $3,500, I work in a hospital. I actually sit in a psychiatric hospital. I floated out to communities. Like I pushed it out the door into community-based organizations. We were sharing like quarters. I don't know, like we were sharing like pennies, right? But we were sharing it. And I think that, as leaders who are trying to lead transformation, we have to think about how are we modeling it in whatever sphere we're working. And so I think that's been helpful, but there is no part of this response that says it's easy. Like it has not been easy for sure. Building relationships, I guess I would also just say having really concrete, tangible things to work on together that are underpinned by a shared vision, a shared goal, and shared values. And those motherhood and apple pie, I don't even know where that saying comes from, but whatever that means, those kind of like really being able to drive people back to the vision that most people around this table today for sure would hold around supporting young people with young people to achieve optimal outcomes as they define them. And then how are we all contributing? I don't know. I think those are my top few things.
Thanks, Jo. It's a really interesting reflection about the different languages that are used in different kind of contexts and how that impacts our ability to really sort of understand and connect. And I was just reflecting that I noticed through the presentation the really strong presence of First Nations centred kind of services. And I wonder if that's been a journey as well. Did it start like that, or is that something that's evolved, or was that the starting point?
For like, I think it's, this is how sometimes the people are so influential. So my personal sort of history involved very early exposure, long before kind of truth and reconciliation language in Canada. So my own personal journey has always included thinking about how we partner with First Nations, Inuit, Métis in Canada, but especially First Nations people with whom I lived and stuff. And so that, I think, also created an opportunity. I think there are many other people who share this too. Like, this is not personal to me, but like just recognizing the strength. Like we often engage around reconciliation and in Canada, like First Nations, Métis, from a deficit standpoint, and like I think wanting to acknowledge and act in reconciling ways around the harm that's been caused, and that is absolutely essential. And there's tremendous strength and wisdom to be learned from. And I think that in Canada, First Nations communities have said to me, like, what is this integrated care thing? Like, that is community. That's not it's not a model. This is how we live. This is how we support young people. This is community. And really learning from First Nations and bringing that in, both informally and structurally, has been important.
Thanks, Jo. And I think there's just one question in the chat, which is about that transition as people age out of the youth services. So just wondering how that works.
So we're super flexible. So we, there's like, especially starting at the young age, like 12, we do have to be mindful of having, 35-year-olds receiving service in the same space. So, we have to define that age, but we really focus on what's developmentally appropriate. So, walk into your typical emergency room at a hospital and probably half the physician residents are 26 years old. And then, that's a very different reflection of opportunity and social determinants of health, and also developmental stage in some ways, right? And then you have other young people who are, not having had those opportunities, or at a different sort of place in terms of what they need in order to be supported. So we really try to focus on development as opposed to age. We don't kick anyone out. And at some point you start to think, well, maybe an exclusively adult focused service might be a better fit.
Fantastic. Thank you. Well, we've gotten to 3:45, so we're going to need to finish. But can I just thank so much Joe for sharing all of that with us. Thanks Shauna and Vivian and Kristen for their reflections, and for Owen, I'm so sorry that we couldn't manage to hear you. And also a big thanks to Origin and Melbourne City Mission for sharing Joe with us, just here for a very short visit. So I do really appreciate you slotting this into your busy schedule. Next week, we're going to have another session talking to Dr. Cameron Parcell and a group of Professor Cameron Parcell, I think it is, and a group of peer advocates looking at the questions around dignity and autonomy in homelessness service use from a client perspective. So that'll be another exciting conversation. I'll put, well, I won't have time to put the link in the chat, but you can find it on the website, and I'll send a follow-up email. But thank you so much for joining the conversation today. It was wonderful to see you all, and I might see you at another webinar in the future. Thanks again.
Thanks, everyone.